So today we will have a few words about hypovolemic shock. Hypovolemic shock is very common in ICU setup. Actually, circulatory volume commonly is decreased due to hemorrhage or sudden decrease in circulatory volume in most commonly decrease in trauma patients. Hypovolemic shock is present when systolic blood pressure is less than 90 millimeters of mercury, mean arterial pressure less than 60 millimeters of mercury, lactates are more than 4. So it could be because of heat loss, because of third species losses like in pancreatitis or any other infections. There can be third space losing is there. Whenever there is increased blood loss, it is directly proportional to mortality of patients. Okay, if other comorbidities are present like heart disease, these also contribute to mortality of the patient in hypovolemic shock. So, lactic acidosis is because of inadequate tissue perfusion. Whenever there is inadequate tissue perfusion, the aerobic metabolism which is going on in tissues, it is converted to anaerobic metabolism, and there is production of lactic acid as a byproduct, and so it causes lactic acidosis. Magnitude of lactic acidosis determines the mortality even if there are no clinical features. So during treating this hypovolemic shock, the it depends upon reversing the hypoperfusion. So there are few principles of treating hypovolemic shock, like reversing the hypoperfusion, maintaining adequate HB level so that tissue oxygen is adequate, maintaining the ventricular preloading, IV fluids, and ultimately vasoconstricts or inotropes like dobutamine. There is classification of hypovolemic shock. It is classified into three stages: usually mild, which is compensated, then moderate, and severe, which is decompensated. During in mild hypovolemic shock or mild hypovolemia, there is less than 20% blood volume loss, or there is 20% loss of volume, which causes peripheral pathophysiology. Is what is pathophysiology? In this, there is peripheral vasoconstriction. Because of peripheral vasoconstriction, the blood which is in periphery, it is moved to center and vital organs are perfused. The perfusion of vital organs is maintained. In moderate shock, there is 20 to 40% loss of blood volume. There is decreased perfusion of kidney, intestines, and pancreas or other vital organs. And severe hypovolemic shock, which is not compensated, it is decompensated. So there is more than 40% loss and decreased perfusion of brain and heart. Okay, so how you will manage this hypovolemia? During management of hypovolemia, immediately we must try to control the source of bleeding. Wherever the source of bleeding, it can be controlled by pressure, ligation, and other lot of methods. And simultaneously, we shall take IV access, bore two IV cannulas, 16 or 18 gauge as early as possible. Okay, so control of bleeding, it can be if it is controlled, then we must go for IV fluid. We must give IV fluids to patient. If it is not controlled, then we must give IV fluids and try to use other methods for controlling bleeding, like embolization, ligation, pressures, and other things. Okay, whenever we take IV access, we must do HB of patient. If it is less than 9, then there is need of blood transfusion. If it is more than 9, hemoglobin is more than 9, we must give IV fluids to patients like NS, RL alternately. Then we should measure mean arterial pressure and CVP. If CVP, number one, there are three conditions in during measurement of CVP and mean arterial pressure. There are three conditions. When CVP is less than 8 millimeters of mercury, we must give IV fluids 20 ml per kg, NS or RL. In second condition, when CVP is more than 8 but mean arterial pressure is less than 60, at that time we must give a NARAD, vasoconstrictor or inotropic agents, NARAD. Okay, in third condition, whenever there is CVP more than 8, mean arterial pressure is also more than 8, at that time we must monitor fluid response by using pulse pressure variation, IVC and collapsibility index, stroke volume variation. Okay, these are the things we can do whenever there is CVP more than 8 and even minital pressure is more than 60. We can. Okay. So what are urgent therapies during management of what are during management of hypovolemic shock? Same ABC, airway control, cardiac or hemodynamic monitoring. When there is blood loss because of thrombocytopenia, we must give platelets or SDPs, FFPs, and we must try to maintain platelet level more than 50. Then adequate factor 7 or antifibrillary like trimazemic acid we must give. Usually we use in trauma patients. Then calcium or magnesium chloride, we know that calcium is required for coagulation. So during hypocalcemia, hypomagnesemia, there is coagulopathy, more bleeding is there. So we must try to maintain physiological levels of magnesium and physiological levels of magnesium and calcium. Rewarming, we know that during hypothermia, in last discussion we saw कि whenever there is hypothermia, there can be coagulopathy. When severe hypothermia is there, less than 28 degrees Celsius temperature, it may cause DIC, some ECG changes like Osborn waves. So we must maintain temperature. We must maintain euthermia. We monitor when we are giving blood transfusion like FFP or other blood transfusions, they may cause transfusion induced lung injury, that is TRALI, within 6 hours. So at or other complication like TACO is transfusion associated cardiac overload or anaphylaxis. We must be prepared for handling these complications. Antibiotic, whenever there is sepsis, in sepsis there are chances of septic shock or hypovolemia, hypothermia, we must give antibiotic as and when needed. Corticosteroids, ultimately whenever there is no response or HPA is suppressed or adrenal injury is there or patient is not responding to all other measures, we must try uh, hydrocortisone or other corticosteroids. Mostly we give hydrocortisone 50 milligram 4 hourly. 6 hourly. Thank you.